to talk to you today about the re-irradiation of head and neck cancers. What do we know and what are the updates? Head and neck cancers are the 6th most common malignancy worldwide. They are a heterogeneous and to some extent aggressive group of cancers because of their genetic complexity, the different sites of the head and neck, and because of the different etiological factors as well. 15 to 50% of the patients worldwide will experience a local regional recurrence with distant failure in up to 30% of the cases. In addition, survivors after treatment are at risk of second primary malignancies in up to 22% of the cases, and the incidence increases with time. 1/3 of those second primary malignancies will arise in the head and neck. Unfortunately, patients with recurrences or second primary malignancies have a poor prognosis with a median survival of 12 months and limited treatment options. If the recurrence is localized, local regional, the cornerstone of treatment will be salvage surgery with a good chance of survival up to 40% at 5 years. But again, unfortunately, 80% of the cases present in an unresectable state because of their infiltrative and multifocal tumors or because of the poor performance states of the patient. Suboptimal outcomes can be anticipated with systemic treatment or radiotherapy because of the treatment resistance. Usually when we give the patient the first course of treatment, you get rid of the most radiosensitive cells, and in the recurrence, you're left with the most radioresistant cells. And also, there is to overcome this toxicity, to overcome this treatment resistance and to limit the toxicity, dose escalated and focused re-irradiation was investigated, but mostly retrospectively. So regarding re-irradiation, what are the possible modalities that we can use? 3D conformal radiotherapy, IMRT or VMAT, and by this I mean the conventionally or the hyperfractionated regimens. As we can see here in this photo, in this figure, as the technique gets more complex, the dose to the normal structures, like here, decreases. As you can see here, the difference between the 2D, 3D, and IMRT, and the dose conformality increases as well. SPRT, actually SPRT is a type of fractionation, not a modality of it. Giving 5 to 30 gray per fraction, 1 to 3 times per week, over 5 fractions. It's a highly focused type of re-irradiation. So as we can see here, this is the distribution with the IMRT, and this is the distribution with the SPRT. The SPRT is associated with better conformality and less dose to the organs at risk. Particle irradiation, proton or carbon ion. Brachytherapy. Intraoperative radiotherapy using either electron beam or HDR brachytherapy. This table summarizes the outcomes with particle re-irradiation, brachytherapy, intraoperative radiotherapy. Of course, all those outcomes came from either retrospective studies or prospective phase 2 studies with very limited number of patients. And each of those modalities has its own drawback. So with the particle irradiation, we have the problem of the cost, availability in the center, and the worrisome late toxicity in spite of decreased acute toxicity. In cases of brachytherapy, it's only most effective in certain sites like oral cavity or oropharyngeal carcinomas, and it has to be performed in a center with expertise in using interstitial brachytherapy in the head and neck. Regarding the intraoperative radiotherapy, it has to be only used in the adjuvant setting after debulking surgery. It has the problem also of availability in the centers and expertise as well. So what about IMRT in re-irradiation? It has increased conformality, better dose distribution, decreased toxicity of course. It was found to have better local regional progression-free survival than 3D conformal radiotherapy, but the overall survival was not changed.
Okay.
It was associated with better outcome if we use doses more than or equal 60 to 66 gray. SPRT, highly conformal, delivers a very high dose of radiation precisely while sparing the surrounding normal structures. It has also additional radiobiological advantages. SPRT maintains the usual pathway of radiation-induced cellular death, mitotic stroke plus or minus apoptosis, but it can also affect the tumor vasculature, causing endothelial cell damage because of the high dose per fraction. It can enhance the anti-tumor immunity by activation of the regulatory T lymphocytes. And actually, this action is enhanced by immunotherapy, which was the base of many trials. Studying the combination of both in treatment. It has shorter overall treatment time, so this decreases the accelerated repopulation and in turn can increase the outcome. Of course, because of the shorter treatment duration, it's more convenient to the patient. The American Association of Physicists in Medicine retrospectively studied 300 patients in 8 studies. They found that certain factors can improve the local control and overall survival if using SPRT re-irradiation. For example, one of those factors was the dose, using a dose of 35 to 45 gray. Histologies other than squamous cell carcinomas, like adenoid cystic, for example, nasopharyngeal or skull-based sites, and if we're treating a second primary versus a local recurrence, this is associated with better outcome. This table summarizes the outcomes with the IMRT and the SPRT. The local regional recurrence with IMRT 65% versus 82% in SPRT. The overall survival is comparable between both, as well as the late toxicity. Although different trials has reported different rates of acute toxicity, for example, in IMRT from 15 to 48%. In SPRT, some trials reported as low as 6% and up to 50%. SPRT has a specific problem or something that we need to take care of, which is the carotid blowout. Some trials has reported carotid blowout in 15% of the cases. It was found that the possibility of carotid blowout syndrome increases if the recurrence to be treated is related to the carotid, invading more than 1/8% of the circumference of the, or if there is skin invasion, or if the dose of re-irradiation to the carotid is more than 34 gray. And if we're treating on daily basis.
Okay.
So what are the factors that can affect the decision to re-irradiate and the modality to choose? Performance states and prognosis. The better performance states and prognosis of the anticipated with the treatment, the more complex technique we can use. Disease extent and volume. For example, if we have a localized recurrence in the nasopharynx, for example, with like less than 35 cc, this is patient is a candidate for SPRT. But if the recurrence is multifocal, the neck and the oropharynx and somewhere else, it's better to be treated with IMRT. The site as well, as we explained before, if it's related to the carotid, we have to see if there's any invasion of the circumference. If it's more 180 degrees, this patient cannot be treated with SPRT. The elapsed duration between the two treatment courses, most studies have agreed that this duration should be at least 6 to 12 months. Of course, the less the duration, the more radio-resistant tumor we're expecting to treat. Surrounding organs at risk and their suggested tolerance. And as Dr. Rami has discussed before in one of the previous lectures, toxicity from the previous radiotherapy. If a patient during his previous course of treatment was faced with grade 3 or 4 toxicities, this patient might not be suitable for any re-irradiation because we anticipate that he will have some increased toxicity as well.
Okay.
What are the requirements in case of re-irradiation in cases of IMRT or SPRT? Precise simulation, contouring, and planning. We need to have precise fixation of the patient with a well-fit mask. Fusion with functional imaging, either PET-CT or MRI, to differentiate between areas of fibrosis and areas of true recurrence. Image verification each session, like for example with CBCT. In cases of IMRT, conventionally fractionated IMRT, we can reduce the image verification to at least twice weekly. The contouring. The GTV includes the gross tumor. The BTV is an expansion of 3 to 5 millimeter around the gross tumor. There is no CTV in any kind of re-irradiation, no prophylactic volume to be included. Most of the trials studying this issue has found that including a prophylactic volume has increased the toxicity, and most of the recurrences later on were found to be at the site of the gross tumor, with very minimal number found outside the gross tumor area. The planning. We expect the 95 to 100% of the PTV volume to be covered by 95 to 100% of the prescribed dose. In cases of SPRT, we can deliver more dose to the GTV, up to 120% of the prescribed dose.
Okay.
Of course, the main problem in re-irradiation is the tolerance of the surrounding structures, especially the neural structures. This was studied in some trials, although the trials are not that strong and they are not many. Most clinicians have agreed that it should be kept as low as possible. One trial, for example, has set a constraint to the spinal cord of a cumulative PED from the two courses of less than 135.5 gray. The brainstem cumulative Dmax of 79 gray from the two courses and D1cc of 60 gray from the two courses. Regarding the SPRT, it has its own constraints. This was studied by Karam et al. In 2016, and this study has proposed constraints for SPRT that I can discuss later on with anybody if anybody's interested. Dr. Wa'il is going to discuss with us later on the role of systemic treatment in recurrent tumors, but is there any role of combining systemic treatment with re-irradiation? It's actually controversial. It was found to improve the response to radiotherapy in some trials and help to overcome the treatment resistance. And also we have additional benefit in cases of immunotherapy added to SPRT, as it enhances the immunological effect of SPRT. In most trials, chemotherapy, targeted agents, or immunotherapy were used in the induction, concurrent, or adjuvant setting. For example, the extreme protocol, which is platinum, 5-FU, and cetuximab, plus or minus sometimes taxane agent, produced a response rate of 36% to 59%. Immunotherapy was found to improve the overall survival, especially in highly positive PD-L1 tumors. This trial was conducted by Dario et al. In 2021. It has tested the use of SPRT 45 gray in 5 fractions, plus or minus concurrent induction or adjuvant systemic treatment. It was retrospective, including 137 patients. The used agents included cetuximab, pembrolizumab, nivolumab, and combination chemotherapy, so it was pretty much heterogeneous. It was found that systemic therapy improved the regional control by about 20%, as we can see in this graph. This is the graph for the distant control. And the distant control by about 38%. And of all the types and regimens of systemic treatment given, concurrent chemotherapy had the highest rates of regional control among all the other options. This trial is currently recruiting. It's the Keystone trial, studying the combination of SPRT with Pembro in patients with locally recurrent or second primary malignancies. It was open to recruitment in 2018. It uses SPRT 40 gray in 5 fractions, plus or minus concurrent and adjuvant Pembro for 2 years. And by the way, they have published the first 7 treated patients as an abstract, and there was no dose-limiting toxicity published.
صح؟ 40 جنيه for 5 days over 5 days. لا مش daily، بقيت مرة في الأسبوع بس even if.
So, is there a role of adjuvant re-irradiation after surgical excision of the recurrent tumor? Actually, the role is controversial. It was found by some trials to improve the local control and overall survival, especially in cases of high risk of further recurrence, like R1, R2 resection, and extracapsular extension of the excised nodes. The dose used is 60 gray if R0 or R1, and 66 gray if R2, if we are irradiating after R2 resection. Our NCI experience, we have conducted a phase 2 prospective trial in the NCI, studying SPRT re-irradiation of locally recurrent and second primary malignancies. It included 30 patients. The dose range was ranging from 30 gray to 50 gray over 5 fractions. 20 patients received radical re-irradiation with a CR rate of 76%. 10 patients received adjuvant re-irradiation after surgery with no recurrence 60%. 2-year overall survival 54%, 2-year local control 54.8%, and 2-year regional control 73.6%. And more than grade 3 toxicity were in 6% only. Okay, so if I want the junior oncologist here to take something from this talk, it would be that the choice, the decision to re-irradiate and the choice of the modality is all about the choice of the right patient. So, for example, the ideal candidates for SPRT are those with good performance status, GTV less than or equal 35 cc, with no direct invasion of the skin, and with no invasion of more than 180% of the carotid circumference. IMRT dose ranges from 60 to 66 gray, but not less than 60 gray by any means. SPRT dose 35 to 45 gray is the best used dose in 5 fractions every other day. They have both comparable treatment results, but with less
أهون ما تبقى
overall
daily
treatment
برضه.
time with SPRT. No prophylactic volumes, no CTV to be used. Addition of systemic treatment can enhance the response. Of course, further validation by randomized phase 3 trials is needed. Thank you.